So then I think Dr. Sawyer's touched on this briefly already. We have our next speaker. He is a respiratory lead pharmacist at North Central London CCG, Darush Attar-Zadeh. Everyone is talking about switching to low carbon inhalers at the moment, but Darush will tell you greener respiratory healthcare isn't just about inhalers. It is about running an effective respiratory medicines optimization program that takes account of environmental considerations from a wider range of perspectives. And some of us in Pharmacy Declares had attended this talk in the Clinical Pharmacy Congress in London this year, and it really resonated with us. So it is our pleasure to introduce Darush.
Hi, Minna, and thank you for inviting me along. Can you guys see my slides okay, just before I get going? Yes, yeah. Perfect. Okay, so I'm Darush, a respiratory lead pharmacist based over in Barnet area, North Central London. I'm very passionate about treating tobacco dependency, and that's something that's been involved in the last 25 years, supporting patients. I mean, during the pandemic, indoor and outdoor pollution has been something that's been on my mind. During lockdowns, there's been a lot more young people starting smoking as well during this particular year. Been tough times for a lot of people, and that's been something on my mind. I think one of the things that we can always think about ourselves as NHS workers, as pharmacy teams or non-pharmacy teams, is what we can do ourselves with regards to the footprint around eating better, moving better. And you've heard a lot already about also practicing better. I think inhalers is going to be the thing I focus on in today's talk, and there are things we can try and push, for example, manufacturers to introduce dose counters on all medicines. I know, for example, Salbutamol, a lot of those particular inhalers do not have dose counters, and patients will not know when they're empty, and that can, of course, contribute to the global warming potential. I think promoting recycling schemes is something that we've got as part of the pharmacy quality scheme over here in England, and we should be promoting that. So because my talk is quite short and I want to leave time for questions, I'll whiz through some of the things. And the good thing is Matthew had covered a few bits on inhalers as well, which was good. So these are my declarations, disclosures. I do order lots of placebos. You might notice I'm surrounded by lots of placebos and tar jars and stopping smoking and lung tubes. I think when it comes to coaching patients on inhalers, we need placebos, and as Matthew was highlighting, it's not easy for patients to get that medication to the lungs. I don't know how many of you have heard of the Primary Care Respiratory Society, but when we think about greener respiratory healthcare, we shouldn't be just thinking of, I don't think there's any really green inhaler. I think there's lower carbon inhalers, but we do need to think far broader, and they've been mentioned in our talks. We need to think about, as pharmacy teams, thinking about getting a sense check when we're checking notes on records to check that the patient's diagnosis is early and accurate. We need to think about that because if we're not treating the right condition, then of course there's going to be a lot of harm to the patient and also waste to the system. And we've got one planet, we all want to look after it, we all want to do our bit. So if inhalers are not used appropriately and the medication is not getting to the site of action, then there's again going to be harm to the patient and waste. So recycling schemes, one of the big things I'm going to focus on in this talk is around personalized and patient-centered care. And yeah, it's good that we can do our bit when it comes to reducing the travel, like drive less, and it's good this meeting is done remotely. So lots we can do. But one of the positive things, and why I'm passionate about inhaler technique optimization, is because if we can get preventative treatment to the site of action, we can reduce the doses. So that again will be great for the patient because less side effects, and also it means less harm to the planet as well, in the sense that we're reducing waste and costs too. It means less trips to the hospital. It means less trips to the GP if a person, GP practice, if a person is using their treatments effectively. So optimal inhaler technique is possible. And I think with lots of great work, and I don't know how many of you have heard of the UK Inhaler Group, but they've got these national standards that we can all sort of look up to. We talk about the 7 steps to good inhaler technique. I don't want to be too negative about metered dose inhalers, but by themselves, believe it or not, as you would have heard in the talk earlier, 9 out of 10 of us healthcare professionals may make a mistake when using a metered dose inhaler by itself. Out of those 7 steps, we might, a study by Baverstock showed out of 150 healthcare professionals, even if you make one mistake, 0 to 10% of the drug could get to the site of action, which is a problem. But the thing is, when somebody says to me, how can adding a spacer be good for the carbon footprint? And how can that be? Because spacers, a lot of them can't be recycled, but they can be. I mean, people have come up with innovative ideas to use spacers as potted plants and various other things. But you can see from this particular study, it was showing that if a person does regularly use their metered dose inhaler with a spacer, then more of the drug can get to the site of action if the spacer is used properly. And dry powder inhalers, people can make mistakes with those as well. So it's not a matter of just saying, okay, let's just try and solve this problem by changing everybody from metered dose inhalers to dry powder inhalers, because there are 7 steps to good inhaler technique when using a dry powder inhaler too. That may include preparing and loading the dose, because each dry powder inhaler is quite different on that, breathing away from the device, the breath hold at the end of inhalation, and of course having sufficient inspiratory effort to get the drug out of the device. All important factors we need to think about. So we all need to act, and I think as part of greener respiratory healthcare, we do definitely need to act. We need to assess the person's ability to use that particular device and finding the right device that fits that right patient. And you'll only be able to do that if you actually have the patient there, either during a face-to-face or video consultation where you can watch what the person is doing, and then checking, for example, if they've got sufficient inspiratory flow to get the dry powder out of the device, or whether they can inhale slow and steady over 3 to 5 seconds. What is their natural maneuver? We then need to choose the right device that fits the right patient. And of course, if that particular device has got a lower carbon footprint, then great news. And we need to consider, for those people who can do slow and steady, we have soft mist inhalers that don't contain aerosol propellant in there. It's using a spring mechanism. So soft mist inhalers are really, really good options for those. But so is a metered dose inhaler and a spacer, if that's the right one for that patient. And then you need to think about if a person can inhale over 2 to 3 seconds, quick and deep. You can get them to breathe out, empty their lungs out and inhale quick and deep over 2 to 3 seconds. Then a dry powder inhaler may be a good option for that person. And then we need to teach and train and coach. Repetition really does matter. So I thought this paper by Usmani, Capstick, Salim and Scullion is absolutely brilliant. And I'd recommend you all keep that as a sort of desktop or place where you can actually refer to it. And they're the 7 steps set by the UK Inhaler Group standards, which I'm not going to go into great detail on that now. But a lot of us will be aware of the NHS long-term plan, and they're talking about all of the great work we've already been doing so far with regards to our sort of sustainability, looking at reducing water consumption and turning off light switches, and really important things that we can do. But lowering the carbon inhalers will deliver a reduction of 4%, which is, you know, when you think of the overall NHS footprint. And other things like anaesthetic practices will also, we can do lots around that, and use of single-use plastics, etc. Now, when you're looking at the metered dose inhaler, all of those metered dose inhalers contain a canister. In that aluminium canister, You'll have active drug, of course, but you'll also have a propellant in there. We used to have something called chlorofluorocarbons, which not only affected global warming potential, but affected the ozone layer as well. And they were changed then to HFAs, which are also known as hydrofluoroalkanes or hydrofluorocarbons. Now, there are two types of HFA. We say there's 134A and there's 227EA. So the one that's 227EA is considered 3,350 times more potent than carbon dioxide. There's only a couple of inhalers on the market, Flutiform metered dose inhaler and Symbicort metered dose inhaler that contains this HFA 227EA. And just note on this Symbicort, it's not the turbohaler, which is a dry powder, it's just the metered dose inhaler. And then there's lots of others that contain HFA 134A, which is around 1,300 times more potent than carbon dioxide. So the idea is, can we move more closer towards what other Scandinavian countries do? And they have around only about 10 to 30% of their inhalers prescribed are metered dose inhalers, most are dry powder inhalers, whereas in this country, in England anyway, it's around 70%. But for dry powder inhalers, as was discussed earlier, we've got to think that yes, it might have less effects on the carbon footprint with regards to global warming potential, but we do need to think about and challenge manufacturers about the actual life cycle of that particular inhaler. How was it born? How was it manufactured? And how was it transported across? How much water was used? How much packaging was used? And also, how is it for example, when it comes to incineration or landfill, what effects does it have there? Because a lot of the plastics in the dry powder inhalers can't actually be properly recycled because it's got lots of different plastics fused. So human toxicity, marine eutrophication and fossil depletion are the things that we might be looking at when we're thinking of dry powder inhalers there. And patients, which is what this is really all about, is patients and the environment, of course, is some of the messaging that they might be getting. And some of the media has made comparisons with one of their inhalers saying it's equivalent to a 180-mile car journey. People do need inhalers to live, whereas car journeys are optional. But I think these comparisons can be useful when because people want to make a real difference, and I think that communication is really important, but we've just got to be careful not to push it too far where the patient feels guilty for using medicines. So NICE came out with a good inhaler decision aid, and they're making comparison. It gives us informed information. One dose of a dry powder inhaler being, for example, 20 grams carbon dioxide equivalent, compared to, for example, one dose, which is 2 puffs of a metered dose inhaler being 500 grams carbon dioxide equivalent. And Ventolin being a particular problem because it contains a large amount of, a larger volume of this HFA 134A. And some of you will be aware of Pressquip, which we use in England to get data and get information, and they make these carbon dioxide equivalent comparisons. And you can see somebody on a Ventolin Evohaler, which is really commonly prescribed, especially if you're prescribing generically. A lot of community pharmacies will store and stock Ventolin Evohaler. So is it time for us to consider branded prescribing for all inhalers, not including Salbutamol these days? So that's an interesting comparison. Some of these Salbutamols are dry powder, and some of them are contain a smaller volume of this HFA 134A, like Salamol, for example. So something before I came on this talk, I was just thinking, you know, conversations us pharmacists might be having with patients. And there's opportunities, I think, for us here. A person might come to us with you know, a lot of patients will have mixed devices. They may be on a metered dose inhaler, they may be on a dry powder inhaler. That dry powder inhaler might be used as their maintenance, and that metered dose inhaler is used for emergency use only. But let's say the person is finding it hard already to use one device, let alone two. I mean, learning one inhaler technique is hard enough, let alone two. And if you've got mixed devices, this could be a really good opportunity for us to try and standardize this particular person. So after inviting them in and reviewing the patient, you might find that they're better suited to a dry powder inhaler anyway, because they've got the ability to inhale quick and deep over 1 to 2 seconds, and that might be good for them. But if you're not having that conversation with the patient, and you've made somebody's decided, let's just change their Ventolin to something else like the EasyHaler device, which is a good dry powder inhaler. If you haven't managed that person's expectations, that person might actually say, look, this inhaler feels very different to the inhaler I used to have. A different sensation. I used to get quite an sensation at the back of my throat when I used the Ventolin. Now that's not there. I'm not sure if I'm getting the medicine. And I've noticed there's quite a bit of a difference in inspiratory effort that's needed. And it might put the person off using the inhaler. Whereas if you've had that proper discussion with the patient to say, this is what to expect, I think that's important. So if a person was changed from Ventolin EvoHaler to and they're on a preventative treatment with a spacer, that's great. And their inhaler technique is suited to, their natural maneuver is suited to slow and steady inhalation over 3 to 5 seconds, then you might consider Salbutamol CFC-free inhaler, for example. That could be different. But it's important, again, to let the person know that there may be some changes in aftertaste. The canister may be noticeably smaller than the one that they're used to, but it does have the same number of doses. It looks smaller though. And you might find, and this is where I think this whole thing around ideas, concerns, expectations, is you may find people just become non-adherent to treatment, and they may actually, it may ruin relationships between practitioner and patient. So using information from greeninhaler.org, I think, is very useful. You know, words like making patients aware that they can really make a difference themselves, being aware of the greenhouse gases that the inhaler they're on is having at the moment, and there are other options available to them. So they're empowered more. I think that could be good. So we need to be trained up on those sort of discussions. And what I'm cautiously optimistic about all of these changes coming through from the primary care network directed enhanced service we have in England, where there's incentives to change people to different types of salbutamol, which has got a lower carbon footprint. I think that's positive, but I think at the same time, if people are just changed, blanket changed, we're going to have some real issues. And this is why a paper I wrote recently with some colleagues was just looking at different models of advice we could give. One could be, model one is looking at just sending out a letter to patients to say, we're changing your inhaler. And this model assumes that, say, 20 or even 40% of patients are non-adherent. That's going to involve patients coming back, traveling back, and being hospitalized potentially and needing additional counseling because of non-adherence to preventative treatment, because it wasn't explained fully. Model two might be looking at somebody who comes in for an asthma review or COPD review, but the clinician is saying, look, we're going to be changing your inhalers over, but what we'll do is we'll review you in a few months' time just to see how you're getting on with your inhaler. And again, I think that's not an ideal scenario, because the patient may just feel, well, why have they changed my inhaler? Why wasn't I shown how to use this? Why wasn't my ideas, concerns, expectations considered here? And model three is more of a targeted approach, where you invite people on mixed devices, for example, where actually this is going to benefit the person, or they're on something like multiple devices. And actually, if they narrowed multiple devices down to 1 or 2 devices, I think that would be good, because you're doing a targeted search. So these are the sort of bits of advice I'd be giving in the Barnet area. The most environmentally unfriendly inhalers, the one a patient can't or will not use. And please don't risk destabilizing any of your well-controlled respiratory patients, and only think about alternative devices for patients you identify as uncontrolled or unsuited to existing devices. I think we can do targeted searches, and I'll give you some examples in a moment. I think there's lots of opportunities and highlighting that, yes, we can say to patients, if they're feeling guilty, why I'm on this inhaler that's causing more harm to the patient, let the patient not, reassure them that there's plenty of other measures they can take, like recycling their inhalers, using their preventer more regularly, and only ordering inhalers when needed, staying active, and trigger avoidance, for example. So not trying to make the person feel like really feeling guilty that they're still on that particular metered dose inhaler. So when I looked at the long-term plan, I was really, again, pleased that we really want to make a difference. And I think metered dose inhalers where a low carbon alternative may be appropriate is definitely a good thing. But the word appropriate doesn't mean a huge amount to me, because if you're a generalist, what does appropriate actually mean? And this is where I think danger can arise, where if done inappropriately and not part of a shared decision-making process by the clinician, not trained in this area, then I think we can this can result in far worse outcomes for the patient and the system and the planet. When you look at the 73 million respiratory inhalers prescribed every year in the UK, we do need to maximise the community pharmacy recycling schemes. We don't want loads of these Ventolin, for example, half-empty canisters sitting in landfill, seeping out into the environment. We're going to have real problems, and we're already having real problems, as you heard from those wonderful talks earlier on. So NICE decision aids does talk about recycling a lot more. And as I said earlier, spaces cannot currently be recycled, but manufacturers, I'm hearing, are doing a lot around trying to change that and form plastics that can be recycled. So that's kind of the sort of, when we think of medicines optimization or cost savings optimization, I think if we do things the right way, we can do some real good. Matthew made some really good points earlier on. Early and accurate diagnosis, stepping patients down appropriately, thinking about the 9.24 million SABA canisters, these blue inhalers. 9.24 million of these blue canisters are used for patients who are over-reliant, as in they've got poor, for example, asthma control. This was from a study called the Sabina study, because if you need to use more than 3 or more canisters per year, your risk of having a severe asthma attack is doubled. So just trying to think, why have we got so many uncontrolled patients who are experiencing breathless moments? A lot of that might be poor adherence to preventative treatment. And so we need to look at the ratio as pharmacists. We need to look at the amount of preventative treatment that person's on, device optimization. We need to think about high dose ICS prescribing by brand. And just how many of us actually do this? Say to a patient that one blue canister should last you 6 months. Because if a person has good asthma control, they shouldn't need to use their blue inhaler more than twice a week, according to the national guidelines. So if a person needs to use that inhaler, which contains 200 puffs in that canister, if that doesn't last 6 months, then that may indicate that person's asthma is not fully controlled. We need to do a lot of education around that. Potentially, that's 1,200 breathless moments if a person has had 6 canisters in a 12-month period. And with poor inhaler technique and poor adherence to treatment, only 12% of that medication will be getting to the right site of action. Correct, and that's not good for preventative treatment either. So we really do need to help people understand that, help all of us understand that asthma, for example, is an inflammatory condition and needs to be treated with anti-inflammatory agents. And blue inhalers are only really reserved for those emergency situations. Some of these slides I've just shown here are from Asthma Right Care, and Asthma Right Care is a global movement to really try and improve and help people live better with asthma. So I strongly recommend you look at that. Okay, so these are the last few examples, and then I'll take some questions. So if I'm doing targeted searches in my local area around trying to help support patients, if I've got a patient who isn't using a spacer with their metered dose inhaler and they have poor respiratory control, but they do have the ability to inhale over 2 to 3 seconds, I will invite that patient in and I'll think, this person, I know I've maybe prescribed a spacer, but they're still not using it after doing an assessment. I would think that is going to be a good, responsible thing to do, and we could potentially help with the greener respiratory health here. If a person, as I said, is on multiple devices, I've seen some people on like a Respiratory device, and then they're on a dry powder inhaler combination, and then they're on a metered dose inhaler. They're on 3 different devices. Why can't we narrow that down to 2 and maybe even 1? If you're using something like maintenance and reliever therapy for asthma, that will help reduce waste, and it also optimize treatments as well. If I've got an adolescent child who's using a metered dose inhaler with spacer and mask, as they're growing older, that young child, I'll be thinking, well, should they actually need a mask? Because above the age of 5, in theory, most people do not need to use a mask with the spacer device. I would invite that person in just to coach them on using a spacer and a metered dose inhaler without a mask. But if I'm finding after doing an assessment that that person's natural maneuver is to do this, then I'll be thinking, actually, there are some licensed dry powder inhaler options available as well. So let's look at that too. And then, as I said earlier, there's going to be some people who are over-reliant on their blue inhaler and only using that one. Should we be moving towards things like maintenance and reliever therapy, where at least every time that person feels they need to use a reliever, they're getting background inhaled corticosteroids? So that's an option for, not for every patient, but it should be done as part of a shared decision-making and with an asthma plan as well. So this is the summary slide. I'm cautiously optimistic we can make a real difference if we work together around greener respiratory health and lowering the carbon footprint. But we do really need to focus on reducing the SABA over-reliance, improving adherence to inhaled corticosteroids, reducing oral corticosteroid use, ideally by preventing exacerbations, appropriate ICS doses. These are all pharmacy-specific things we can look at. MART when required in asthma, potentially, Ventolin dispensing, and looking at the ratio of DPI versus metered dose inhaler. So I'll stop there, and thank you very much for your listening there.
Thank you so much for that, Darush. Loads of chat going on in the chat box. You might want to have a look at that yourself later, but there's a few questions that's come through for yourself. One, I think, is more to gain your opinion on this. So Callum's asking, he's doing some research this morning about Ventura being bought by Philip Morris International, the huge tobacco company responsible for the production of 150 billion cigarettes a year. Now, Ventura produce a lot of low carbon inhalers, Trelegy, Anoro, and Cruise. Is this something people are taking into account? Is it ethical to give COPD patients inhalers directly funding combustible cigarettes?
It's a great question, and I'm extremely disappointed that actual takeover went through. Because on the one hand, I'm trying to treat tobacco dependency, which is a chronic relapsing long-term condition in itself. And the last thing I want to do is line the pockets of these manufacturers who make cigarettes. But what I would say is we need to dig deeper and find out exactly what the relationships are between the different manufacturers who and what Ventura's actual involvement is. And I'm Primary Care Respiratory Society, who I'm part of their executive committee. I'm looking at that in more detail because, and I know there's some great advice that's been coming out already around, you know, what we should do. But first of all, patient is our most important priority. Right device that fits the right patient. I wouldn't make any drastic changes, because some companies don't have much involvement, and actually it's past involvement. Others still have direct involvement, and then we need to come up with, as all these charities that are involved in respiratory need to come together and come up with a guidance that's clear for everybody.
Lovely. Okay. A question from Amanda. How are people counselling on inhaler technique in a current climate, I presume, in cause of the pandemic? And she's finding it difficult to order placebo devices from pharmaceutical companies for inhalers.
Ordering placebos, I've been okay ordering them. I'm surprised that you would find that difficult. Because a lot of the manufacturers do have placebos, and they'll be delighted to share them. But I'm more than happy if you want to contact me directly and find out, because I've got contacts from those companies. I'm sure that we'll be more than happy to get you placebos. But one thing I am worried about, in the last year or two, inhaler technique, I think, has been neglected in a big way. We've been under so much pressure, and this is from patient survey that's come out from the Task Force for Lung Health that was asking patients about inhaler technique. There are ways we can assess technique via video consultations, but telephone consultations, can you really coach a person on how to use their inhaler via telephone? It's not ideal, but you could probably do some bits, and this is why the Task Force for Lung Health have come out with a guide around remote consultations around doing inhaler technique, which I can put something in the chat box a little bit later on, so if any of you want to access that document. But I think, yeah, new medicine service with community pharmacy is a good opportunity for catch-up inhaler techniques, and they would have had to have done the CPP online accreditation. So we have to have skilled clinicians who are coaching patients who can go on and deliver this. But I think this is definitely something we should be pushing hard on in the immediate future, because sharing a link from Asthma UK or Right Breathe, for example, I don't think is enough to help a person understand their technique.
Absolutely. Darush, thank you so much again. There's a few more questions that's not been answered that's come through the Q&A and the chat box. Hopefully you'll be able to stay and help answer them for us with your expertise. And hopefully I think everyone in the chat box has found your talk really useful today. So thank you again for joining us.
You're welcome. Thank you.